So I'm Jasmine. I've met some of you guys. I'm one of the new PEM fellows, and today I'm going to just be talking a little bit about bronchiolitis. So do as we say, not as we do. Our aims for this lecture today is to define what bronchiolitis is, talk a little bit about its pathophysiology, the variation of its presentation, evidence and practice guidelines, and then management in the ED. What we actually do in our ER, what many PEM ERs do, and then versus what the literature actually says to do. So bronchiolitis is a clinical syndrome. It generally occurs in children that are less than 2 years of age, and its peak incidence is about 2 to 6 months of age. It's generally categorized as an upper URI-like symptoms, followed by a lower respiratory tract infection with inflammation. It's generally a self-limiting disease. Most children who do not require hospitalization recover by 1 month fully, and it accounts for about 100,000 cases, admissions a year into hospitals around the United States at an estimated cost of $1.7 billion. So it's actually the #1 cause of hospitalization in infants and children. So it's a pretty important lecture, and it's something that you would definitely see, especially even in our ER. So let's talk a little bit about the respiratory tract. It's divided into upper and lower airways. The upper respiratory tract includes the nasal cavity, the oral cavity, and then the infection generally starts here. So parents usually won't come in during this part of the infection. They'll just kind of tell you, yeah, my kid had a little bit of a runny nose and cough. Usually they'll present when it starts in the lower airways. The lower respiratory tract starts at the larynx and it involves the trachea, which then bifurcate into the bronchi and then the bronchioles, so hence the term bronchiolitis, and then you terminate into the alveoli. So as the virus spreads to the bronchioles, it causes an inflammatory response, which causes mucus plugging, edema, and you can also have necrosis and loss of the actual epithelium. So on the right side, you'll see a normal bronchial tube, and on your left side, you'll see one that has an active bronchiolitis. You can see that there's mucus buildup here, inflamed tissue that can cause smooth muscle tightening around the actual bronchial tubes. This can lead to collapsed alveoli, air trapping, atelectasis, obstruction. Biopsies and autopsy samples over 24 hours after the infection actually include ciliary disruption, parabronchial lymphocytic infiltration, and bronchial cell necrosis. So again, the clinical course, generally you have a prodrome that starts with the URI, usually days 1 to 3. And then you see kids that present with the lower airway symptoms. The peak days are 3 to 5. And then it's followed by generally a gradual reduction. So recovery can last up to 8 to 15 days on an average, but full recovery actually can be up to a month. So if you have a child that presents into the ER a month after they were admitted, they could still be having just some of those residual effects from their initial bronchiolitic infection. For those that are hospitalized, the median length of stay was about 2 days. And obviously this course can be prolonged in patients that have pre-existing conditions or infants that are younger than 6 months. So let's talk about viruses a little bit. RSV and influenza are generally only seen in the winter months, but actually can be seen up until April. So we're in RSV season right now. So you will likely, if you are in the PDER, see a patient that has RSV bronchiolitis. Parainfluenza types 1 and 2 are generally seen in the fall. And then we have parainfluenza that's seen in the spring alongside human metapneumovirus can actually make kids very sick as well. And they can peak, they're seen throughout the year, but they can peak later in the winter and spring. Adenovirus is generally seen throughout the year, but endemic usually in the later winter and spring. RSV is alone accounts for about 80% of all bronchiolitic cases in the US. Its incubation is around 2 to 8 days. It's a single-stranded RNA virus. There are generally 2 subtypes that present in outbreaks. Its inoculation occurs with respiratory droplets, and it can remain infectious on countertops for over 6 hours. Direct contact is actually the most common route, but it can survive several hours on hands and fomites. literally virtually all people by the age of 2 have been infected with RSV, and a previous infection of RSV actually doesn't protect you against a reinfection. So if you are reinfected, but if you are reinfected in the same season, the symptoms are generally milder. So let's talk about the clinical presentation a little bit. It can vary from mild, moderate to severe. There's a spectrum. Those hospitalized generally present in moderate to severe respiratory distress, unless you have a kid that's obviously less than 2 months of age. Then sometimes, even if they're in mild distress, they're at an increased risk of apneic episodes, so we would admit them sometimes. When looking for a severe exacerbation, it's always important to keep in mind that the respiratory rate can either be high or low. It's usually associated with grunting, some cyanosis. And mild, moderate, and severe, you're going to have a little bit of an increased work of breathing, some tachypnea. You really want to pay attention to the respiratory rate, how they're retracting, and expiratory wheezing. You're going to see, when you listen to a kid, you're going to see that they have a prolonged expiratory phase during an active bronchiolitic infection. This is very similar to an asthma exacerbation in kids that are over 2. So the assessment is really important. It can vary, and it will require serial observations, and it can change minute to minute. So you have mucus plugging and unplugging alongside the air trapping we kind of talked about earlier. So, you know, if you go see a patient and they look like they're in moderate respiratory distress, and then you present them to an attending and they all of a sudden look a lot better, it doesn't mean your exam was wrong. It just means maybe they have unplugged a mucus plug. So it's really vital to count the respiratory rate over a minute. And then you want to first attempt to suction them and position the patient before you count the respiratory rate to decrease their work of breathing. And again, there's no one right scoring system of respiratory distress. It's variable. So be patient with yourself. So there's some manifestations in children. They can be as subtle as nasal flaring, or they can be as severe as tracheal tugging. So you want to look above their trachea to assess for tracheal tugging. You want to look in between their ribs to see if you find any intercostal retractions, and then underneath their rib cage to kind of assess for any subcostal retractions. So we're going to do a question. This is going to give me a little bit of a talking break. So if someone could read it for me, that would be awesome. Yeah.
Previously healthy 2-month-old boy presented to the clinic with a 12-hour history of breathing fast, rhinorrhea, congestion, and cough. Baby was born at 38 weeks gestation, but was small for gestational age due to placental insufficiency. Mother had an uneventful pregnancy and breastfeeds. Family history is significant for asthma. Baby's diagnosis having bronchiolitis. We explained to the family that because it's early in the course of the disease, the clinical course could potentially worsen. Which of the following is the most important predictor of disease severity in this patient?
Okay, so let's try this. So I'm gonna have you guys all pull out your phones. Oh. Okay. How do I do this? David. So it has to be in like presentation mode. Sorry. If this doesn't work, you can just do it the old-fashioned way, but I thought this would be really interactive and fun. Okay. That's so weird because it's working for me at home. Okay. It's okay. So we'll just do it the old-fashioned way. So A is age, B is born SGA, C is breastfeeding, family history of asthma, and then male sex. So I guess we can just do it by, so whoever thinks it's A, raise your hand. Okay, whoever thinks it's B, raise your hand. Okay, whoever thinks it's C, raise your hand. Okay, D. Okay, and then E. All right, so I think most people said SGA. It's really important to look at the end of the question. So the most important predictor of disease severity, right? So kind of talked about it a little bit, but age is actually the most important predictor of disease severity, with the greatest risk being from 1 to 3 months of age. That's generally when protective maternal antibodies wane. Other risk factors include kids that are less than 8 weeks, obviously. So again, if you have a child that is less than 8 weeks, comes to the ER, even in mild to moderate respiratory distress, they're at a higher risk of apneic episodes, especially if you're evaluating them earlier in the course of the infection. So it's totally appropriate to admit these kids for observation. Most infants tend to resolve with bronchiolitis, but those with risk factors have a more prolonged course of infection. So yes, SGA is an answer, but less than 8 weeks is the best answer. Premature infants, less than 36 weeks, those with history of BPD or CLD, airway deficits, immunodeficiencies, cardiac disease, and neurological disease are also high risk factors for serious infection. So we have a lower threshold for admitting these kids. Other risk factors can be social, so smoking, daycare settings, crowded households, households with multiple children, young children can also serve as risk factors. The diagnosis of bronchiolitis is made with a good history and physical exam. You do not need any supplemental studies to do so, and routine testing is not indicated to make a diagnosis. If you do indeed want to swab for RSV and flu or any other viral etiologies, keep in mind that these tests cost money and it's not necessary, but it can help with epidemiological data, patient cohorting, especially if you're having a kid that you're trying to send up to the floor and you don't want them to interact with other kids and spread RSV. Currently, there are about 6 available PCR tests that have about 100% sensitivity and around an 89% specificity. These are pretty good tests. And again, they can be tested positive in up to 4 weeks in infants, but the average duration of RSV is detected up to 11 days. Chest x-rays are really, really not indicated, and it can often, you have an increased risk of radiation, inappropriate antibiotic use when you do a chest x-ray. If you do indeed decide to do a chest x-ray, you can often see that you have hyperinflation with hyperlucency of the actual lungs. Here you can see the flattening of the diaphragms and parabronchial thickening. In this x-ray, you have areas of atelectasis that at times can be misinterpreted as a consolidation. This happens a lot. And again, then at that point, you have a lot of inappropriate antibiotic use. And then when the kid gets to the floor, they have to be on antibiotics for 10 days for a viral infection. So chest x-rays, try not to use them if your clinical suspicion for bronchiolitis is high. They're really unnecessary and can be quite harmful. So another question. Anyone else? I don't know all of your names yet, so. Okay. Okay, so how many people think a trial of albuterol? Okay, how many people want to do oxygen? Awesome. Gave away the answer. How many people want to do CBC and blood cultures? Get a chest x-ray. Great. And then E is start broad spectrum antibiotics. Great. Yeah, exactly. So ABCs are never wrong in ER, even in PDER, they're never wrong. So this kid is hypoxic, and the mainstay of therapy always begins with supportive care and respiratory support. So for treatment, you want to make sure they have adequate hydration and respiratory support. You want to keep their oxygen levels above a 92, even though there's some new data that's coming out that says over 90 is enough to oxygenate tissues in bronchiolitic infections. We like to keep them above a 92. You want to start fluids to cover for insensible losses, but keep in mind that you want to avoid fluid overload because that can lead to pulmonary congestion and worsening outcomes. So you don't just want to keep bolusing these kids when they're in the ER for multiple hours. ADH at times can be elevated, leading to urinary retention, hyponatremia. So monitoring urinary output is very important, especially when they're on the floor. IV hydration is necessary a lot of the times due to how tachypnic these kids are. They have an increased risk of aspiration, and that way you can ensure adequate hydration and avoid aspiration. Respiratory support in these infants is often provided in a stepwise approach. We often start with nasal suctioning and supplemental oxygen, and then those who need more, who progress over this trial, we start on high flow nasal cannula or CPAP. We'll talk about high flow nasal cannula in a little bit, and if obviously that fails, you want to intubate. In children with continued apneic episodes, loss of their protective airways, hemodynamic instability, those should be intubated early. You obviously don't want to try high flow if they can't maintain protective airways. You want to intubate those kids fast. So high flow nasal cannula and CPAP are used to reduce work of breathing. They improve gas exchange. You can avoid intubation this way. It's a non-invasive method that permits high inspired gas flows with or without increasing oxygen saturation. The air is humidified and flow rates over 6 liters can generate some PEEP. So it helps keep the lower airways open. This is a really good chart for those who are initiating high flow therapy in pediatrics. Generally, we like to start the flow around 1 to 2 liters per kg per minute. And we escalate to as needed to minimize work of breathing. So you want to pay attention to retractions, tachypnea, nasal flaring, grunting when you're assessing how much flow you want to start on these cannulas. The maximum flow rate should be 2 liters per kilo per minute, with an upper limit of 50 to 60, which is what I think you guys use on the adult size as well. The common concentration is started, FiO2 is started generally around 50%, titrated up or down as needed to achieve a target saturation around 94 to 98. And obviously as the work of breathing improves, the flow rate can be titrated down. The FiO2 for the delivered gas should be reduced based on oxygen saturation and determined independently of the titrated flow rate. And then obviously you want to make sure their cannulas fit well. So the outer diameter of the nasal cannula can't be more than 2/3 of their nares, and the inner diameter can't be more than 50%. Let's talk a little bit about hydration. Again, we don't just bolus these kids. You want to start them, and a lot of the times they're in the emergency room for hours. So you want to start them on IV fluids, especially if they have these insensible losses and they're very tachypnic and you don't want to feed them because there's an increased risk of aspiration. You want to provide fluid therapy to meet their physiological losses, so insensible losses and urine losses. What we use is, in pediatrics, is the Holiday and Seeger equation. It was like in the 60s, and they found that there was a direct linear relationship between physiological water needs and energy metabolism. And the relationship between weight and energy metabolism was found to be non-linear. So they constructed this curve, which you can see is in the middle. And it compromises 3 linear sections. So that's kind of where we get our 4-2-1 rule that we mentioned to you guys when you're in the PDER. So you have the section between 0 and 10 kilos, 10 and 20, and then 20 and above. Okay, so this is the 4-2-1 rule. So you want to start these kids on maintenance IV fluids. Generally, that's sufficient enough to cover for even their insensible losses. So for the first 10 kilos of a child, you want to start 4 mLs per kg per hour for the first 10 kilos. For the second 10 kilos, you want to do 2 mLs per kg per hour. And then for the third, it's 1 mLs per kg per hour. And then obviously, if you multiply that by 24 hours, you can get the rate for the 24 hours. So let's do a quick calculation. What would the maintenance fluids, and I know a lot of you guys have PD stat, but this is a really good thing to learn for pediatrics because we often ask you these questions in the ER and we're like, what would be the maintenance fluid calculation for someone that weighs 22 kilos per hour? So not for 24 hours, per hour, mLs per hour. So if we did the 4-2-1 rule. Don't use MD Calc and don't use PD stat. Would it be helpful if I like wrote it on the board or went back to the calculations? Yeah, okay. This is a rule. So you have a 5 kilo infant. And remember, anyone less than 10 kilos, you want to do 4 mLs per kg per hour. So that one would be 20 mLs per hour. So that's from 0 to 10, 10 to 20, and then 20 and above. 10 to 20 is 2 mLs per kg per hour, and then 20 above is 1 mLs per kg per hour. So if you think about it, anyone over 20 kilos is automatically going to have 60 mLs per hour, right? So you add 1 mL per kg per hour over every kilo. So you have a kid that I'm asking you is 22 kilos. So you already know that it's over 60. What is it? 62? Yeah, perfect. Yeah, so it's 62 mLs an hour. Does everyone get that? Is that an actual yes or like maybe yes? You sure? Should I write it on the board or everyone's good? Okay, because it's yeah.
Everyone who's over 20 kilos, we automatically know it's 60, and then every kilo they're above 20 is going to be 160 per hour. So once they're above 20, that's the easiest. You already know they're getting that 60 cc per hour, and every kilo that they're above 20 is going to be 160. So that sometimes can be helpful, but then knowing, like most of the time our kids are less than 20 kilos, and knowing the requirements for those patients also.
Yeah. Yeah, so 20 mLs per hour. But if you're really worried about fluid overload, you can start at 10. But you don't necessarily have to bolus these kids unless you think that they're very, very dehydrated. Again, because of the pulmonary congestion. Okay, so do as we say, not as we do. There was a 2014 article in Pediatrics that came out that talked about everything that we do in bronchiolitis that's wrong and that we really shouldn't be doing, but we do anyways. So there's a lot of data with each of these things. Bronchodilators generally will temporarily improve some clinical symptoms, but they do not affect disease resolution. So they just make us feel a little bit better. The need for hospitalization or the length of stay. So a lot of the times these kids can develop asthma in the future, about 1/3 of them. So, you know, some ER docs feel like it's appropriate to trial one albuterol and see if the wheezing improves. But again, don't treat them like an asthmatic. Don't slam them with steroids, slam them with 3 duos. If you want to try the bronchodilator, try one bronchodilator and then reassess them and see if it actually did help. If it doesn't help, then there's no point in continuing the bronchodilators because it shows that it really doesn't do very much for bronchiolitis. You want to try to avoid epinephrine in infants. There's been a lot of studies that show that this doesn't improve outcome. It doesn't improve length of stay. It's just something, it's a tool we have and sometimes we use it, but there's data that supports that it doesn't really do very much. And so these guidelines came out in 2014 and they recommended not to administer nebulized hypertonic saline in the ER, even though when these patients are admitted, it can be shown that it does shorten the length of hospital stay, but in the ER, it shows really no effect. In 2015, a meta-analysis came out that said hypertonic saline, if you are choosing to nebulize anything, hypertonic saline is superior compared to normal saline, and it can indeed decreased length of stay, and decreased rate of readmission. But this is still being challenged as well. You don't want to administer steroids because this can actually prolong viral shedding. And then again, antibiotics, please try to stay away from these unless you really think that there is a bacterial infection brewing. And they've done studies that this is a very low risk. Usually it's around less than 1%, but this can be justifiable only when kids are intubated, they have they're mechanically ventilated, you're worried about aspiration pneumonia, but antibiotics are really not indicated. And a lot of the times they're used because we do get those chest x-rays, we see the atelectasis, we think it's a consolidation, and we start them. And then you are succumbing this child to 10 days of antibiotics for a viral infection, breeding antibiotic resistance, giving them diarrhea, all these things that exist with antibiotic use. There are some supplemental therapies. Synagis is probably the only product out there right now to reduce the risk of RSV. It's a monoclonal antibody that targets the epitope of the RSV-F glycoprotein, and it has been shown to reduce the RSV hospitalization by around 50%. There's pretty strict guidelines on who can actually receive this. Generally, it's infants that are born less than 29 weeks, those with BPD or CLD, those that have neuromuscular or congenital anomalies, those that have acyanotic or cyanotic heart disease, and CF was just added as well. During the RSV season, clinicians may administer up to 5 doses of Synagis, and it obviously it has been shown to decrease the hospitalization rate in these children by 50%. So we'll do another question. Anyone? That's not David.
6-month-old boy got meningitis and RSV bronchiolitis. Parents are very concerned about their 2 older children.
Okay, so you want to administer Synagis to the 6-month-old is A. Anybody want to, you can read them and then we'll go through them. Okay, A, does anyone want to do A? B, begin prophylactic antibiotics to the other children. C, emphasize appropriate hand washing. D, ensure all household members are up to date with recommended vaccines. And then E, keep older children home for school for 7 days. Good. So I think 90% of you chose C, emphasize appropriate hand washing. And that's true. When speaking to families, family and caregivers of young infants and children, we should emphasize that hand washing will decrease the spread of bronchiolitis. We do a lot of anticipatory guidance in the PDER, so this is actually very, very important. And again, with soap and water, sing happy birthday 2 times, it does decrease the exposure to young infants. Those are ill. If anybody's sick at home, tell them not to kiss the baby, because obviously they can transmit it during with respiratory droplets. Yes, we can. So when we can feed, we can hydrate, we can encourage breastfeeding, we can discourage smoking, and you obviously want to vaccinate where you can. There's been studies that show there's really no statistical difference between NG feeds and IV hydration. So if you can't get an IV, you can attempt for NG feeds. Okay, last question, I promise. Anyone else? This one's a little easier because it's like the same family.
The parents of the infant described in the previous scenario are concerned whether this RSV episode would result in late pneumonic sequelae. The clinician reassures parents that the overall prognosis for infants and children with bronchiolitis is good with minimal later sequelae in low-risk patients. In explaining the potential long-term sequelae for children that have the bronchiolitis episode, the clinician will most likely mention which will follow as a common sequelae should be given bronchiolitis.
So A is COPD, B, epilepsy. C, reactive airway disease. Beautiful. D, recurrent pneumonia. And then E, sinusitis. Okay. So the most common sequelae to bronchiolitis is the development of reactive airway disease or asthma later on in childhood. There are some reports that say it's between 20 to 60. Usually we kind of say about 1/3 of them will develop asthma in the future. Those obviously infants that have severe bronchiolitis, ones that require hospitalization, and ones that are less than 6 months of age have a higher risk of developing asthma later in life. And obviously you want to get a family and personal history of ATP because that puts them at even a higher risk. So some take-home points. Diagnosis is made by clinical assessment. Respiratory support and hydration are vital. Management can vary from practitioner to practitioner, but there are some guidelines in place. Environmental factors matter. Anticipatory guidance matters. And then if you're ever in a calculations bind, download PD-Stat. I mean, we're all in the ER, so PD-Stat's a great tool in terms of calculating other medications, but it can also help you with the fluid calculations. And these are my citations, and I want to thank Dr. Chow. I want to thank Adam and Rosie for helping me with this lecture, and then Dr. Kano as well. All right, thanks, guys. Any questions? Yeah, what's up?
So I noticed earlier, PowerPoint said that before you calculate give suction and then put it in a position where it be better. Can you tell me more about the position that?
Yeah, so you want to make sure that their airway's open, right? So you suction them, you keep their airway kind of like neutral and open, and that will help them kind of open up their airway. You really don't want their airways to be kind of like closed off, them looking at their feet, them kind of lying in the bed, which is what happens a lot of the times because they're going to be tachypnic that way. Yeah, so that's generally how you position a baby. That's a good question.